everyone, my name is Dr. Catherine Palmarola, coming to you from IVFMD's South Miami location, and I'm very excited to share with you the very first week on fertility. So the first week of every month, I'm planning to discuss a fertility topic, infertility topic, anything at all is possible. This week, our topic is fertility preservation. So before we get started with your questions, I have just wanted to give a broad overview of fertility preservation, how this came about, and what it involves. So fertility preservation was actually first developed for cancer patients, patients who were either planning to undergo chemotherapy, radiation, or cancer-saving surgery that was expected to impact their future fertility, either the testicles and sperm production or the ovaries and egg production. So prior to undergoing treatment, they would go through the procedure of either saving their eggs or producing embryos or saving ovarian tissue or testicular tissue before undergoing the treatment that is expected to hinder their future fertility. This is an option for both men and women who are facing for treatments that may impact their fertility. And it's now considered a very important part of the initial diagnosis of cancer. And both the fertility organizations and oncology organizations or cancer organizations agree that this is critical to the first conversations when cancer is being diagnosed. So at first this was experimental. Now it's considered no longer experimental according to the 2013 ASRM guidelines because our technology for egg and sperm freezing has luckily drastically improved. Beyond cancer patients, this can also be considered for patients with lupus who are facing gonadotoxic therapies or treatments that will hinder their egg or sperm production, as well as sickle cell patients or anyone who's requiring a stem cell transplant. All of these therapies can potentially harm their future fertility. So this is a medically indicated fertility preservation. However, now we do have the option of elective fertility preservation for technically men, it's possible as well, but women who are not ready to have children, who don't currently have a partner, or just not ready personally to have children at this time, they have the option of freezing eggs or embryos. So in terms of methods for fertility preservation for medically indicated patients, this includes hormonal suppression to reduce activity of the ovaries. This is the evidence for the effectiveness of hormonal suppression of the ovaries is fairly inconclusive. There are other methods that are considered more effective for fertility preservation. If someone is undergoing planned radiation to the pelvis, it's possible to have the ovaries transposed or moved outside of the range of radiation. Similarly, if a patient has cervical cancer, it's possible to do fertility-saving surgery, just removing the cervix, in order to preserve the uterus and the possibility for carrying a pregnancy. The classic forms of fertility preservation are both egg and embryo freezing, and we'll go into detail about that soon. And then finally, for pediatric patients or patients who have not yet gone through puberty, there's the option of ovarian tissue cryopreservation, or saving and freezing part of the tissue of the ovary, because before puberty, you're not yet ovulating and producing eggs regularly. So this is still considered experimental, but potentially, given all the research that's been done on ovarian tissue cryopreservation, it may not necessarily be experimental for much longer, which is very exciting. We'll get back to this a little bit as well, but in terms of the process for egg and embryo freezing, this only takes about 2 weeks, so we're really not delaying the planned chemotherapy or planned treatment for cancer. It can definitely be integrated prior to those treatments in order to preserve fertility. Additionally, when we're talking about a breast cancer or hormone-responsive cancers that have estrogen and progesterone receptors, we do have modified treatment protocols that can prevent spread of disease, prevent further exposure to estrogen, which of course is a concern during our fertility treatments. Additionally, there's many organizations out there that can help with the cost of fertility preservation. These organizations include Livestrong as well as many others that cover almost 100% of the costs of fertility preservation, so that's wonderful. In terms of methods for elective fertility preservation, this is when we're talking primarily about people who've gone through puberty, so they have the option of egg freezing or embryo freezing. Roughly, again, it's a 2-week process. You are taking injection hormones for an average 10 days and then undergoing a procedure in the office under light sedation where we will remove the eggs from your ovaries. So it's about an average of 10 days. You do have frequent office visits for your ultrasounds and blood work where we're monitoring the growth of your hormone, growth of your follicles, growth of the eggs. And then it's a very quick procedure in the office on roughly on average the 12th day to remove the eggs. The eggs will be evaluated that day and then frozen the same day as the egg retrieval. If a couple or a patient opts to freeze embryos, the eggs are combined with sperm that day, grown to the blastocyst phase, which is on average 5 to 6 days, and then embryos are frozen. So that's the slight difference between egg and embryo freezing. I want to stress that fertility preservation for elective purposes is by far from an insurance policy. It does not guarantee you 100% a baby in the future. However, it's our closest that we have to an insurance policy. It's kind of tricky in terms of when is the best time to freeze your eggs. Of course, if you are younger, you will have more eggs. They will be of higher quality. However, since you're younger, you have longer time that you may end up meeting someone and not needing to use those eggs. In contrast, if you wait too long, we will have fewer eggs. Those eggs will be of lower quality. But of course, if you're older when you freeze your eggs, you are more likely to use those in the future as your own egg supply diminishes with time. There have actually been some cost analyses performed to identify what is the most cost-effective time to freeze your eggs, and that seems to be, the consensus is around between 35 and 38, when you still have enough eggs that the egg freezing process can be successful. The quality of those eggs has only just started to decline, and you're more likely to use them in the future, so a lower cost of long-term storage if you were very young, and better chance of success of pregnancy when you do come back to use those eggs. So cost can vary drastically between clinics, so I definitely recommend you be in touch with your fertility clinics in terms of the exact cost for your area. And then at the end, we can touch on some emerging technologies that I recently learned about at the Philadelphia ASRM conference recently. Just some very exciting new research out there about up-and-coming research and technologies for fertility preservation. So, moving on to some of the questions that you guys have sent in. Thank you so much. So one listener asked, how many times can you undergo an egg retrieval? So this is an excellent question. Whether you're freezing eggs or whether you're going through fertility treatments or regardless, most fertility clinics do put a limit on the number of retrievals a woman should undergo. It certainly probably varies between fertility clinic, but from my experience, it's on average about 5 to 6 retrievals. And the reason being that you're undergoing a procedure, we're exposing you to medications, this comes with risks. If you're undergoing IVF cycles for fertility treatments and it hasn't worked after 5 to 6 cycles, it's time to kind of readdress and come up with a better solution because further cycles are unlikely to improve your success necessarily. Additionally, there is the theoretical concern of future cancer development. While the research on cancer in response to IVF treatment is varied and lacking very strong evidence, there was actually a recent article out of the UK last year that suggests a link between high number of IVF cycles, more than 5 cycles, and the development of in situ breast cancer, so local breast cancer, not breast cancer that has expanded, but certainly for that reason and the theoretical concern of cancer in the future with many, many IVF cycles, it is recommended to not pursue more than 5 to 6 IVF cycles. Another common question is, what is my risk of ovarian cancer? There has not been strong links to just straight up IVF cycles and ovarian cancer. It's more linked to the overall diagnosis of infertility, and specifically a diagnosis of endometriosis, and patients who have undergone ART or IVF cycles with endometriosis have a slightly increased risk of ovarian cancer in the future. So for all those reasons, it is recommended to pursue no more than 5 to 6 IVF cycles, but certainly something to discuss with your provider. Another question that came in was, what does it mean to have a positive EIP? And what can I do to reduce the toxicity in my uterus? So what is EIP? This is endometrial immune profile. And it's sometimes considered to be this is a fairly new exam, and it's considered for patients with recurrent pregnancy loss or recurrent implantation failure. The implantation of the embryo remains a big black box in the field of fertility. We have many, many studies looking at all other aspects of fertility, but implantation kind of remains elusive. However, there is growing evidence to suggest that immune function, innate immunity, acquired immunity, antibodies, and natural leukocytes, natural killer cells, these immune functions may play a very important role in implantation. So the EIP, or immune profile, is one potential study to evaluate the immune activity in the uterus. So when it comes back positive, this may suggest that there is an over-immunity or an overactivity of the immune system, specifically within the endometrium, that might be preventing pregnancy from implanting or prevent pregnancy from growing. Now, what to do with this is still very controversial. Some of the potential therapies out there today for overimmunity in the endometrium include IVIG, intralipids, or steroids. These are very controversial. There is not strong evidence in support of or against any of these therapies. So, whether clinics offer these services certainly varies. In contrast, if your endometrium is found to have diminished immune function, not enough immune function, the thought is potentially we need to ramp up the immune activity through an endometrial scratch procedure. This additionally has limited evidence, and as further studies are coming out, it's showing that the endometrial scratch really does not impact future fertility ability to get pregnant. So still very much of a black box, but something that hopefully, as additional research is coming out, we will be able to understand much better. Great. So one of the additional questions that came in is, how many eggs do you need to freeze for one baby? So this is a great question. It's a question that we don't have an answer for, but there is actually an excellent tool out there that I love to use with my patients. It's a calculator that was developed by Brigham and Women's to estimate your rough chances of pregnancy after freezing X number of eggs. It dramatically varies based on age. So naturally, younger patients will need fewer eggs to give a higher potential of pregnancy. Older patients, given the lower quality of those eggs, will need higher numbers of eggs in order to guarantee, which we can never guarantee, but in order to have higher chances of pregnancy. So this website is called the BWH Egg Freezing Counseling Tool. If you just Google that, it'll pop right up, and you can certainly play around with it in terms of your own age, numbers that you got from your egg retrieval, or potential numbers based on rough egg counts or egg estimates that you've been given by your provider. And I always reference this tool before egg freezing consults, after a patient's gone through egg retrieval, to help decide, are we happy with this number, or should we do an additional cycle in order to better guarantee baby. But again, as I mentioned earlier, egg freezing is not 100%. It does not guarantee a baby in the future. Certainly you may have heard the news stories from a couple of years ago, the Washington Post woman who froze eggs many years ago, came back to use them only to have zero success. So those cases certainly do exist, but again, egg freezing is not an insurance policy, but are the closest that we do have. A final question that came in earlier was, why would you get a high number of eggs retrieved, but only a small amount that we're able to freeze? So during the stimulation process, we're attempting to grow as many eggs as possible. We can't see the eggs, we only see your follicles, and it's assumed that the follicles contain an egg. During the egg retrieval process, we drain those follicles and then identify the eggs in the embryology lab. We are ideally looking for metaphase 2 eggs or mature eggs. So this is based on the appearance of the egg. We can determine its stage in development and how much mature or immature the egg is. And it is the metaphase 2 eggs that are able to be fertilized with a sperm. So most clinics or most fertility providers freeze only metaphase 2 eggs. Some providers also freeze metaphase 1 eggs, which is the stage just before the mature metaphase 2 egg. But that can explain the difference sometimes between the number that you hear before leaving your clinic and the final number that was frozen. You may have gotten many eggs, but if not many of them were frozen, that means that there was a high percentage of immature eggs. This might mean a different stimulation or a longer stimulation might be needed in the future to try to improve the number of mature eggs, but it can be something that is tricky to identify ahead of time. Mature versus immature eggs. So that can explain the discrepancy between number of eggs that were obtained and number that were finally frozen. Some clinics do freeze the metaphase 1 eggs, as I mentioned. This would require, when it comes back to use those eggs, that egg has to develop to the metaphase 2 egg before it can be fertilized with sperm. So this requires in vitro maturation or maturing the egg in the laboratory, which not all fertility centers are capable of, and the technology for is still very much in development. So for the most part, it's the metaphase 2 eggs that we are looking for. Okay, so just looking through some of the questions that are now coming in. Is a 3.2 TSH level considered to be hypothyroidism? If so, does that need to be fixed in order to start IVF? So great question. TSH is the thyroid stimulating hormone. It's reflective of your thyroid function. For people who are not attempting to get pregnant, a thyroid level below 4 is considered normal, 4 to 4.5. Above that, we would be worried about hypothyroidism. However, in patients who are attempting pregnancy, especially if you're in our fertility world, we often manage thyroid levels that are below that number. We are hoping to have a TSH level of 2.5 or lower to optimize the pregnancy outcomes. So most likely the overall thyroid or free thyroid level is normal, but when we see a TSH level that's above 2.5, we would consider that subclinical hypothyroidism, and many providers would treat that. It can certainly vary from clinic to clinic. I personally do treat when it's over 2.5, again, to optimize pregnancy outcomes. So I would recommend that it is treated before an IVF. So I don't actually have any further questions unless additional ones come in. I just wanted to share with you, as I mentioned earlier, when I was attending the ASRM conference this past year in Philadelphia, I learned about some of the new emerging technologies for freezing eggs and sperm, which I thought was pretty exciting and wanted to share with you. The success of egg freezing very much depends on the facility that you are freezing your eggs at, meaning the process that the eggs are being frozen, and eventually when you come back to use them, the thaw process. I strongly recommend freezing eggs at a fertility center because they have experience in both freezing, but then eventually using those eggs in the future, thawing them, which is very critical to the survival and success of those eggs. So in order to kind of streamline that process and remove possible human error from the situation, there is emerging technologies to automate the process of freezing and thawing eggs, which can remove possible human error and hopefully improve outcomes for patients. We've certainly been in circumstances where we've received eggs from other facilities and eggs were lost because the thaw process or the way in which the eggs were frozen was either not well documented or an older technology, and the eggs are lost. So if we are somehow able to remove human error and improve the freezing and thawing process of these eggs, I think this will dramatically improve outcomes for patients. So that was exciting. Additional developments, which I'm not sure how I feel about just yet, is the possibility of freeze drying sperm and eggs. And this is being developed because of the big space issue that these cryotanks take up. Currently, frozen eggs and frozen sperm are stored in small vials and kept in vats of liquid nitrogen to stay at a below 190 degrees Celsius temperature for decades and decades until they're ready to be used. These vats of liquid nitrogen take up a lot of space, especially when I was in New York. Real estate is extremely expensive. There's not significant amount of space for large vats of cryotanks for all these specimens. So if we are able to remove the need for cryotanks, liquid nitrogen, freeze dry sperm and eggs for dramatically saving on space. So this is an interesting technology. Right now, it's only in development in animal studies. Certainly a lot has to be done to prove the technology before we use it for human eggs or human sperm. But that's, potentially much space-saving, cost-saving, new technological advancement. Pretty exciting. Then finally, some very interesting developments and research are being done in Asia with regard to, as well as America, but the furthest advances currently are in Japan in terms of developing eggs and sperm from stem cells. They are getting very close to being able to use skin stem cells from a sample of human skin and developing that into a sperm or an egg. Most close to developing into sperm. Eggs are more complicated, more complex, larger stem cells, but and sperm are much smaller than the egg, but they are very close to being able to, using genetic technologies, turning skin stem cells into gametes. This is exciting, especially for patients who've been through cancer and have depleted their ovarian reserve or their testicular reserve, especially for pediatric patients who were not even through puberty and able to go through egg stimulation or provide an ejaculate specimen to freeze sperm. This is a technology that will allow these patients to have their own biological children. Similarly, patients who have gone through, who have diminished ovarian reserve, early menopause, this provides potential for egg formation after that time. So exciting emerging technologies, obviously a lot of ethical possible barriers and a lot of research still to be done before it can be used in the fertility clinics, but I thought very exciting news in terms of the fertility world. Anyway, I think that was all of the questions for tonight on fertility preservation. Once again, thank you so much for joining me. This was the very first week on fertility. I am planning to do a fertility topic of anybody's choosing. You can certainly send me ideas, and we will continue this next month. All right, thanks again for listening. Take care.